Okay, welcome everybody. Thank you for joining us for our SRMA Teaching Series. This is the 7th session of the series, and today we'll be looking at how to conduct a meta-analysis. And delivering the session today is Dr. Connor Gillespie, who is an F2 doctor on a specialised foundation programme in clinical neuroscience at Cambridge. He graduated medical school with honours from the University of Liverpool, and he has an integrated MPhil degree in surgery and oncology. He's a former chair of the Neurology and Neurosurgery Interest Group and will be starting a Neurosurgery Academic Clinical Fellowship in Cambridge in August. He's published extensively in journals and has even produced a book titled Neurology and Neurosurgery 200 SBAs for Medical Students. Now, just a reminder, please fill in the feedback form to get your certificate of attendance. I'll put it in the chat partway through the session for you. So that's all from me. Thanks, Connor, and I'll hand over to you.
Cool. Thanks, Jacob. Sorry, everybody, about the lateness. There was a 9-year-old who arrested on the ward, so I just had to sort them out. Just for context, before I start, could you guys just post in the chat just what stage of training you're at? Is that okay? It'll just help me tailor the talk. If you just put what stage you're in, that would be really helpful. Then I can I know you're all on projects, but I think it will be helpful. Okay, so 3rd year. Okay. Let's see. Okay, so we've got a couple of people. Clinical years, medicine. Year 1, year 3, year 6, year 4. So most people are kind of medical students. Okay, and you're already working through a project or an idea, so you've been taken through the steps. That's fine. That's good. Okay, great. So we'll get started in that case. So that's a variety of years of med school, really. That's fine. I'm not sure if let's just share the screen. Can yourselves, Jacob or Neeraj, can you just tell me if you can see this? Can you see the screen?
Yeah, I can see that.
That's fine. Okay. That's good. So we'll just get started in that case. All right, so welcome to Meta-Analysis 1 Theory. So we'll do 2 talks. We'll do 1 talk this week on the theory and then the next week on the practical examples. So I'll basically be taking you through an example. This is just all the building blocks you need to get there. So what we'll cover is, as far as meta-analysis goes, why you should do one, when to do one, how to do one, and then some useful resources and things that basically lessons you can take from it to prepare yourself next week. Next week, we'll also cover some written and practical. We'll go through the practical steps of doing a meta-analysis using some examples. I think people should be aware of why they should follow the advice given in the teacher, really. So I've been involved in approximately 25 systematic reviews and meta-analysis, around 14 of which are published, as you can see there. And there's another 5 or so in review, but the 14 are just meta-analysis only, so not systematic reviews by themselves. If you include systematic reviews by themselves, there's approximately 30. So I've definitely made a lot of mistakes across those number of publications, so hopefully it will be helpful for you guys. So what a meta-analysis is more or less you're just combining two or more results to produce, or from studies to produce an overall result. My friend, strangely enough, described it as the easiest part of a systematic review, and to avoid a pile-on, I've not named who he is, because I think meta-analysis is something that you think on the surface, if you've never done one before, you think this is actually very difficult, and it's a really complex statistical method. It's going to be almost impossible to produce the results. However, this isn't the case. It's pretty straightforward to do. Once you have done one, you could, in theory, do 30, and I think that's why I've done quite a lot, because it's actually relatively straightforward once you've done 1 or 2, and you are aware of your methodology and the theory behind it. More or less, in a summary, it's just sort of pooling the study data to produce an overall result. So if you just pool that, then you produce one single result as a combination of studies. When you should think about doing a meta-analysis, or when is the right time to do meta-analysis, is probably the most difficult thing. You need to satisfy a few criteria. This is according to sort of the Cochrane handbook. So I'd recommend using that handbook for your guide on how to do a meta-analysis as a first point of call. When you should do a meta-analysis is firstly when you have more than one paper in a study. People ask me a lot, Connor, how many studies do I need to have a minimum of, what if I've only got 3 studies or 4 studies or like 6? Do I need to have 10 studies or more to do an effective meta-analysis? And the reality is no. Statisticians will tell you that you only need to do 2, you only need 2 papers really to do a meta-analysis. If the papers are okay, then the methodology still stands. But more importantly than the numbers, you really need to have a good, clean data set when you're pooling and when you're answering that question. The reason behind this is anyone could do a meta-analysis, but to do a proper one and to do it properly using clean data and homogeneous data that will give you an answer to the right question rather than just some misinterpretation based on differences in each study that have contributed to the results they found. That's kind of the art, really. So you have to be very selective when you do it. If you have studies with different population sizes, so you have some studies with 20 patients and some studies with 10,000 or 100,000, then meta-analysis is a great way to combine those results rather than saying, 4 studies of 5 people said that this treatment was negative, but 1 study of 2,000 said it's positive. So it will help iron that out and give you one overall measurement. It's also good if you've got contrasting studies. So if you have studies that have different conclusions in your systematic review, let's say if you've got 4 or 5 that think amlodipine is the best and most effective blood pressure medication, and then you have 4 or 5 that say, well, actually it's ACE inhibitors. If you have studies that differ in the literature, then it's great to pull them all and then to give a definitive answer. And it's also good if you just want a round number for something, as in if you just want to combine everything to give one single result. It's important to appreciate when not to do a meta-analysis as much as it is when to do a meta-analysis. We really shouldn't be doing a meta-analysis just because you want to, because you think it's going to make your paper look better, or because you just want to do it to kind of show off your statistical prowess. It's really not the best thing to do if your data has significant heterogeneity or the definitions and populations are different in the studies you've included. We will discuss this a bit later. And it's also important not to do it just because you have 2 studies. You have to have a plan and a target for what the meta-analysis result is going to produce. As in, do you specifically want to know if a medical treatment reduces blood loss, in a quantifiable measure that you can then combine to form one result from your systematic review? Or are you doing a meta-analysis because you think the technique will make your paper better? It's usually pretty clear cut as to what you want to do. If it's option A, then go ahead and do the meta-analysis. If it's option B, then I wouldn't do it. A good example of when not to do meta-analysis would be a question such as, what types of devices are available in medical education? I guess what types of, smartphone devices or virtual reality or 3D devices are available? Because your research question is inherently exploratory. You're not aiming to compare 2 things or some treatments. You're just aiming to describe and evaluate the literature. And I think if your systematic review is kind of like that, as it's mainly not numbers based, it's mainly sort of ideas and concepts based, then I would suggest going against meta-analysis. And in fact, your paper will probably come out much stronger if you selectively don't do it and justify why. I would also say not all data is created equal. So just because you have numbers in front of you in forms of papers, if they're not using the same definitions, the same populations, and the same outcome definition, then it's quite difficult to justify including all of them in your study. I'd say not all data is created equal in that measure, but you'll get more used to it as you kind of progress through your different projects, and some of you may already have that knowledge to hand. This is just discussing the levels of evidence. I'm sure they've been over this in the talks in the past. More or less, I just want to use this to say a meta-analysis or a systematic review is only as good as the data that you analyze. So, for example, if you only have cohort studies in a systematic review, its highest level of evidence will always just be level 3. It is not ever going to go higher. So hopefully that should deter people from doing a meta-analysis unnecessarily, thinking it's going to change their study and make it the highest form of evidence. It's really based on the literature that you actually include. Here's a little bit of information regarding the different theory types for meta-analysis, as in the different types of meta-analysis one could perform. Essentially, that's driven by the data that you have and the clinical question or question you're trying to answer. I'll go through all of these in depth using some illustrative examples, but the most common is going to be a meta-analysis of binary variables and groups. There's other ones like meta-analysis of continuous data. For example, does a certain treatment reduce volume loss in mils, depending on the group? So if your measurement is milliliters or hours or days or weight, that's a good one to use. You can meta-analyze single data, which I'll explain. And you can also meta-analyze diagnostic accuracy. These are generally the most common ones that you can use, and I'd especially advise the ones to learn about as a beginner. The most common type is a meta-analysis of binary variables. This is the most common one you'll use. Essentially, it means you have a primary outcome that is binary. For example, a yes group and a no group. Did the primary outcome occur? The example from a publication that I have is comparing two treatment types, so VPS being shunt and ETV being a sort of endoscopic third ventriculostomy. They're both types of neurosurgical procedures, and the outcome is preventing recurrence in hydrocephalus. So my outcome recurrence, as in did the patient have a recurrence on their scan requiring surgery, yes or no, is fairly evident that you can measure this equally between all your studies, and you can meta-analyze this data quite well. Now, this plot on the right-hand side looks complicated. We will dissect it in one of the following slides, what everything means. But it's just to let you know that really the data that you're working with is not that complicated. This table in Excel on the bottom left shows the exact data points that I have collected and inputs to make this chart. So all I've got is ETV, the amount of cases that recurred, shunt, and how many shunt cases recurred. I also have the study, the name of the author. I have nothing else. So this should really prove to you that if you have the right code, doing this process and doing the steps, you don't have to do anything crazy with your data set. If it's lined up right, you only need sort of 3 or 4 variables to actually create this full meta-analysis. So hopefully that's one nice myth busted. Oh, there's also, essentially this is using the binary example, and I'll go through like the chart and what it all means in one of the following slides. This forest plot, which is the plots generated to showcase the results of a meta-analysis, that's what these plots are called. If essentially the continuous outcome and variable is a number. So as I said before, it's kind of like hospital stay in days, operation time in minutes, minutes of exercise, volume of blood loss, etc. But the most important thing is the groups are still binary, as in there's 2 groups. So in this meta-analysis, we looked at the effect of tranexamic acid, which is a treatment stop bleeding, in surgical patients. So we had a TXA group and a no TXA group in randomized controlled trials. And we can more or less see that in all the studies, they have a mean volume of blood loss and a standard deviation. This was all just extracted from the papers that reported it, and it will kind of pull them together to give you a result, which I will explain. Another type is meta-analysis of proportional data. So in this category, it's slightly different because there's no comparator groups. So you're not saying in this treatment group or this observation group, is there a difference? And I want to compare the two. You're just saying you have one single group. So let's say if I want to find out in my population what percentage of patients with a subarachnoid hemorrhage develop low sodium, so develop hyponatremia during their hospital admission. So I'm not comparing them to say like, a non-subarachnoid hemorrhage group or a general public group. I'm just focusing on my population. So you can do a meta-analysis of proportions, which will just give you a specific percent. So it won't give you an odds ratio, which I'll talk about, it will give you just a percentage. So you can see at the bottom right-hand corner of the screen, this just says 37%, and it gives you like a confidence interval, which we'll go through. This is the important slide. It's how to navigate the forest plot and understand what it means. Most people will have been taught this already, but I figure it's just important to go through just in case there's anything you might miss. First bit, slide should work. First bit is the study. So on the forest plot, you have all the studies that you have to kind of type in your Excel or your data points. So usually I put the first author and the year of publication. As long as the style is uniform, that's fine. This is your event page. So in your group, you just have to include, say, so this is comparing, this forest plot is comparing, so basically vasospasm events in patients with hyponatremia compared to no hyponatremia, so normal sodium levels. In each study, you should have, the two groups should be pretty separate, pretty clear. You should have a total number of patients. So in this one, in the hyponatremia group, there's 111 patients and 58 of them developed vasospasm. In the normonatremia group, there was 89 patients and 39 developed vasospasm. And if you plot it the right way, you'll see a bunch of squares and box and whiskers. This is the odds ratio. So the odds ratio is basically the odds, more or less the Quinn study, using that as an example, so it's 1.4. So in this group, the hyponatremia group are 1.4 times more likely to develop vasospasm than the normonatremia, and the confidence interval is shown there. So it's 0.8 to 2.46. That's just shown by the boxes. Essentially, all those results will be kind of put together and given an average at the bottom, which is the red diamond. So you can see that it's 2.93 here. So it suggests that patients with hyponatremia are 2.93 times more likely to develop vasospasm on average, as opposed to people with normal sodium. The next part on the right-hand side is the weight. This is referring to the populational differences that I spoke about in the example before. So each study is going to be assigned a weight to what it contributes towards the overall meta-analysis figure based on firstly the population size, and secondly its deviation from the expected mean. Okay, so let's take for example the study. Let's just say the study at the top, so Quinn 2020. So you've got about 300 patients there. So it's given it a weight of 8.4% out of the total. And let's take another one. So let's take one like this one, Nakagawa 2010. It's got about 80 patients. So you can see it's assigned at 3.7%. So a weight that's proportional to the population. It's also proportional to how it deviates from the standard. So Nakagawa might be slightly less because it deviates from the mean. So it might be 4% normally, but I just ignore that and appreciate that they'll be in different places and it will pump out one single result. The model is presented here. So this, I'll talk through the software used to generate this plot shortly, but this model, which I'll explain, is which model you make the meta-analysis based on. There's, in summary, two types of models. There's fixed effects and there's random effects. Most of the cases you'll use random effects. So if you're ever not sure, just pick random effects. It's more justifiable to researchers. Essentially, what that means is random effects is that you're expecting to have significant heterogeneity within your data sets. And I will explain what that means in the following slides. If you essentially have no heterogeneity, you'd use what's called a fixed effects model. A fixed effects would just give every study essentially the exact same weight, regardless of population size or the odds ratio itself. So it would just assume all studies are created equal and they all are the exact same. So I'm just going to give them the same weights. I'm just going to get an even measurement of the results. Inspecting this plot this bit further, the random effects, you can see the heterogeneity is defined by an I-square value. So that's 71%. This is generally quite high. So I'll explain what that means later, but essentially heterogeneity means that you can see there's quite a variety of results here in this data set. Some are, that one's 10, that one's 7, that one's 1, and that one's 0.13. So they're kind of all over the place. And it also suggests that the populations and the definitions used in all these studies differ significantly. That's not a problem because the random effects model takes this into account, but it's just something for reference. So a fixed effects model would not be appropriate in this case. And finally, you have your overall odds ratio as I described. So your forest plot will go to one side, and if the diamond extends and doesn't touch 0, or it doesn't touch 1, because essentially you want it to be more than 1. If it's more than 1, then it increases the chances. If it's less than 1, it decreases. And your confidence intervals don't intersect 1, then you've got a significant effect. A quick note on the funnel plots. So most tests will produce a funnel plot alongside a forest plot. So your funnel plot essentially it's a bit difficult to describe, but it's just a measure of something called publication bias. What that is in a lot of studies that are small, so generally speaking, smaller studies with less patients or participants tend to be negative more often, as in they don't lead to positive results. So what they do then is they essentially will keep them, they'll not publish them, or they won't end up being published or presented, but the big ones will. So what you look for is sort of a gap on the bottom left-hand side, which you can kind of see here, because in theory, as your odds ratio goes up, essentially your effect size goes up, your standard error should also go up as well, reflecting kind of the smaller study sizes. I wouldn't get too caught up on that at the moment, because I think that's not the purpose of the talk, but just keep an eye out, because that's something that will be generated with your plot, and you will need to understand what it is and have a basic understanding. I've touched on it already, but the next part is talking about heterogeneity. So there's essentially differences within your studies that could affect your outcome outside of the exact numbers that you see. I like to think of it as two main ways that a population can be heterogeneous. It can exhibit heterogeneity. The first is in your age bracket. So, basically in your population differences. In an example that I'd show, let's say if you have one study that only includes patients over the age of 80, compared to one study that only includes patients under the age of 50. By default, the over 70 group is going to have higher mortality, and that would affect your odds ratio. But it's not due to any of the treatments you've looked into. It's literally just because the population's older. Another example is your outcome heterogeneity. This is very common. So most studies don't use the same definition for their outcome. Even something like recurrence could be defined in so many different ways. Some people could define recurrence as appearing that way on a scan, and some people could define that as requiring an operation. So they, it's so bad that they also have clinical symptoms and they need an operation. So you can see that if those two definitions are used, you might end up with different numbers, even though the results in the data might be the exact same. Essentially, it just results in a misbalance in the study, which could then affect the conclusions that you make. So it's really important to use measures of heterogeneity, such as the I-squared statistic and random effects models, to make sure that you don't miss out on that. I think we've discussed this already, and we've talked a little bit about random effects and fixed effects. But essentially, you can, it's not demonstrated very well here, but my suggestion is to use random effects as much as you can. You'll use it as your baseline, and then probably never really, unless you're pretty experienced and you know what you're doing, then you can think about fixed effects. Most studies will have a high degree of heterogeneity. You can see at the bottom diagram forest plot here that's labeled B. This actually has an I-squared statistic of 0%. So it means there's almost no heterogeneity in the results, and therefore you could kind of justify using a fixed effect. But most of them will look like the one on the top. It has an I-squared of 90%. So you should be thinking about using random effects in most cases. And I think statistically that's the method you're least likely to be pulled up on. Another thing you could potentially consider is a sensitivity analysis. This is a good principle to use. It's something that isn't used very much in big meta-analysis and papers, especially when there's a beginner. But essentially, I kind of group this similar to subgroup analysis. They are two different things, but this principle essentially includes repeating your data after changing your definition to kind of account for confounding factors. A good example of this is, let's say you've got 15 studies, and let's say 10 of them are high risk of bias. Sometimes studies that are high risk of bias have misleading results, or let's say you've got loads of randomized control trials and you have a lot of non-randomized studies. Sometimes their methodology can influence the outcome and the result that you see. As we said before, not all data is created equally. So you can look into doing a sensitivity analysis, which is where you might, say, for example, remove all of the non-randomized trials or all of the high risk of bias studies, and then repeat the results to present and then represent the forest plot to see if it changes the results. You can see in the example presented, I've taken the same diagram we used before, and I've removed all the high risk of bias studies, and you can see the odds ratio doesn't really change. It goes from 2.93 to 3.07. So the bias isn't a significant confounder in this data set. How to do a meta-analysis itself? All you need is the data that I've shown you. So very simple. You need a software program that can do it, and you need the code / the right buttons to press to generate the plots. That's what we'll showcase for you next week. There's a few different platforms that I recommend you can use. I don't know if I've listed them down. I don't think I have. But essentially, the 3 platforms that I recommend are, there's RStudio, which is what I use, but it uses coding, so I wouldn't recommend that for a beginner. Essentially, there's like the Cochrane kind of tool, so I'd recommend using that one in the first instance. And there's also one called SPSS, which is sort of button-based, that now does meta-analysis. So you can definitely give those a try. And I think if you're first starting out, I recommend the Cochrane tool first of all. But that's what I'd suggest. I wouldn't suggest going into coding ones straight away. But next week we'll go through it and I'll show you using all these platforms anyway. So I wouldn't be in a rush to try stuff. You can definitely wait till next week's practical examples. And I think that's the rest of it was just more information that I've discussed previously. But I hope that all makes sense. And next week we'll go through some practical examples. In the meantime, if you have any questions, here's my email. So just send it my way. I think that's us done.
Brilliant. Thanks, Connor. What I'll do is I'll post the feedback form in the chat. And if everybody could please fill that in to get your final certificate. And if you have any questions, pop them in the chat or email Connor. Do you mind popping your email in the chat so people have it? That'd be brilliant. Thank you.
Excellent. Well, any questions, they can definitely email me.
Fab. Okay. Brilliant. We'll leave it there then.
Okay. Right.
Thanks, Connor. That was really good. Thank you.
Thanks. Okay. All right. Yeah, they've asked about the mentorship program, but that's on me.
That's all right. I'll answer. Cheers. Thanks.